when we started a number of years ago, interRAI Services wanted to promote research, and so we were approached by the Research Network to initiate an emerging researcher grant to enable an up-and-coming researcher who's using interRAI data in their research to join us here today. And today it is my great pleasure to let everybody know that Wei-Lin Chen is our recipient this year. And just a little bit about Wei-Lin is that he is a postdoctoral research fellow at the New Zealand Policy Research Institute at Auckland University. An economist, his recent interest centres on designing and evaluating algorithms to improve decision-making in aged care and elderly abuse systems. And he completed a PhD in economics at the University of California, San Diego in September 2023. And you'll be hearing about his exciting research soon. However, he has been doing a lot in the elderly abuse sector, and I see Tim nodding, so he's doing well. So Wei-Lin, if you would like to please come up.
All right, thanks for having me. I'm Wei-Lin from Anxiety Policy Research Institute at AUT. Today I'm going to talk about the impact of residential care subsidy on aged residential care residents' health trajectories. Disclaimer, this project uses IDI data. All the results and interpretations are my own. Access to residential care for vulnerable older people is crucial. Currently, NZ government provides residential care subsidy to vulnerable people identified from two dimensions. First, it's health needs, and second, it's financial means. All right, so let me walk you through the process of residential care subsidy application and the interRAI assessment used along the process. First, an older person who are interested in moving into a long-term care facility will have to first book a needs assessment from a needs assessor. Here, interRAI home care assessment will be done. After that, the assessor will then discuss with the older person and the family and discuss about the care plan. If the older person decides that he or she wants to move into a long-term care facility and also wants to apply for the residential care subsidy, then he or she needs to submit two things. First, it's a needs assessment certificate that's just done by the home care assessment process. Send this to the Health New Zealand. So that's to the first triangle. That would show evidence that this person has some health needs, that the certificate says that this person we recommend needing long-term health care, residential care. The second thing to submit is a residential care subsidy application for the financial means assessment to work and income. In this, you will have to describe the total assets that you possess. There, the eligibility rule is that the total asset value will need to be below certain thresholds, also depending on the family structure and those kind of things, all right? After submitting those, the older person will move into an aged residential care facility and complete a long-term care assessment, LTCF assessment within 21 days. Work and income would then advise the subsidy application outcome to the older person, Health New Zealand, and the ARC facility. Health New Zealand will then directly pay the residential care subsidy to the ARC facility. For all the period that this older person is in a ARC facility, there will be a LTCF assessment done every 6 months. The subsidy may not only grant access to the residential care, but also enable the older people to utilize more healthcare services, because essentially it allows the older people to have more disposable income. The subsidy may also directly affect older people's mental health. This leads us to the research question for today. Does receiving residential care subsidy affect older people's mortality risk? To answer this question, I construct the data in the following way. And I have two goals in constructing this data set. First, I want to find the people who potentially apply for the residential care subsidy. Currently, I do not have that data. I do not have the label that this person apply in the data set that I use. To do this, I do the second bullet point here, that I know that for everybody who wants to apply, they would definitely need to have a HC assessment before. So what I did was I select those people who had an HC assessment before their first LTCF assessment with less than 2 years between those two assessments. The second criterion is that I choose people whose first LTCF assessment that was between 2016 to 2019. The choice of 2016 is because since 2015 July, I believe, New Zealand started mandate the LTCF assessment. So that means since 2016, then I can guarantee that this person is in, everybody who is in the ARC facility would have the LTCF, right? The choice of 2019 is because this will allow me to have long enough time horizon to look at their mortality risk at different years. Other data that are used with health data are all coming from the IDI interRAI. Residential care subsidy comes from IDI ad hoc MSD. Socioeconomic variables, I have two. One is home ownership that I identified from 2013 census. The other is the deprivation index of the individual's residence. This I used the 2018 deprivation index. To estimate the impact of the subsidy on mortality risk, I estimate multivariable linear regression models. The outcome variables are mortality, which is binary, 1 disease, 0 life, measured at 1 to 4 years after the HC assessment that's assessed right before they move into the ARC facility. The most important variable here is the subsidy, which is 1 if they receive the subsidy at the beginning of the ARC residence, 0 otherwise. I have a bunch of other control variables, including the home ownership and deprivation index. Importantly, for the health dimension, I include two things. One is the home care assessment. Where was it down? The HC assessment before they move into the ARC facility, where was that down? Was that down in the hospital or not? So if it's done in a hospital, that means, in general, that means it's more serious situation. The second thing needs a little bit more detailed explanation, but we'll discuss more if you're more interested in this. I'll give a very brief description. So it's a health index that is, this is the following is what I wanted to do. I wanted to assess on the day of the HC assessment, if this person directly moves into the ARC facility, what's the 3-year mortality risk for that person on that day? All right, that's the goal I wanted to do. How did I do that? I used the first LTCF assessment. I used all of the interRAI outcome scales there, and then use that to predict the 3-year mortality risk. That's my prediction model. I then bring that prediction model, apply that to the HC assessment data. So that was down on the HC assessment, all right? Using that, I construct that health index. Other variables I also include are the demographic variables, age, sex, prioritized ethnicity, and some location and year variables to control regional fixed factors and time trends, the DHB specific and HC assessment year specific dummy variables. To argue that the beta coefficient here that I estimate is really capturing the impact of the residential care subsidy, I will need to rely on a strong assumption of selection on observables, meaning that after controlling of the X, the epsilons are uncorrelated with subsidy, which is a really strong assumption. And at the end of the next steps, I will try to tell you that how do I want to deal with that in the future. Before I jump into the results, let me first tell you how do those two groups of people compare to each other. The people who receive the subsidy compared to the non-recipients, they're less likely to own a home. They're more likely to live in deprived areas. These two are not surprising because those are correlated with the total asset value, right? Now, the third thing is using the health index that I just described. That's down from the HC assessment. Those people who receive the subsidy are actually healthier at the time of the HC assessment. This might look a little bit unintuitive, but here's my take. I essentially probably include a lot of people who did not apply for residential care subsidy. So there are a lot of people who are really unhealthy at that stage and they really need to move in. And so there are those people who would always move in regardless of what, and they did not even apply for the residential care subsidy, all right? But having all of this tells me that I really need to control for the economic status and initial health conditions to really try to make these two groups of people comparable to each other. And I also have more tables to show you about how different they are if you're really interested in the magnitudes in Q&A. Here's the meat of today. Let me tell you what I'm plotting here. I'm plotting 4 regression results, 1 to 4 year mortality risk. And I'm plotting the predicted probabilities of people with subsidy and without subsidy. And you can see that people with subsidy have lower mortality risk. The first year, second year, third year, all the way to the 4th year. Know that this is relative to the data of the HC assessment. The gap, look at the magnitude for the first year, is about 4.5 percentage points compared to 0.279, which is the predicted mortality risk for the people without subsidy. This is about 16%. So this is quite a large magnitude. And all of these are highly statistically significant. The second result today is that now I only look at the first year mortality risk, but I wanted to know if the impact of subsidy is different depending on people's initial health. What I did is I categorized people into 5 groups based on their health index that I just described. You can see that the group 1 is the most healthy. The group 5 is the least healthy. Look at the group 1, then the reduction of the mortality risk is about 2.4 percentage points. This gap will then even further widen by 3.4 percentage points when we reach group 5 to 5.8 percentage points, meaning that the impact is larger for people that it has poor initial health. Next steps. So essentially, I wanted to make us having more confidence that this estimate can be something that's really causal, that we're really capturing the impact of subsidy instead of something else. To do that, I have to first figure out a few context details, and I'll be really happy if somebody in the audience or online know the answers to these questions. First, it's can the subsidy applicants actually know their application outcomes before they even move into a ARC facility? And if that's the case, well, then the subsidy outcome will then directly impact their decision of whether to move into the ARC facility or not. The second thing is, and this is, I would like to get these data, is the best option that I can see for this project going forward is to compare two groups of people who have very similar total asset values, but one group happens to be just below the threshold. One group happens to be just above, what did I say? Below and above, that's what I wanted to say. And so these two groups of people supposedly should be very similar. And they're just around the threshold, but one group is eligible and one group is not. And so comparing those two groups of people would be a very compelling way to decide that there will be some impact. It's actually some impact from the subsidy. To get this, I would need the asset value from the working income. Finally, and you might wonder that it seems that I didn't use much of interRAI data so far. Well, I try a little bit, and then most importantly, this is really the power of there is really power of periodic LTCF assessments, because we can know many different health dimensions, right, for all of these people. So I can see which dimensions was impacted by the subsidy. Well, I have not talked to you about that because I have not figured out a way to solve the following issue, which is there will be cases where older people lacked an LTCF assessment before they passed away because they're hospitalized or they return to the community. So this missing problem, it's kind of serious, and it's not a trivial one in terms of the number of missing in the data set that I can observe. So I have to first figure out how do I deal with that. Finally, to explore the mechanisms that drive this mortality risk reduction, what I have in my mind is first I have to see, and goes back to the quality indicators. Does the subsidy actually kind of induce people to choose different ARC facilities that I don't know, maybe they are now they have more resources to choose better ARC facilities. I don't know. And second thing is maybe they have the disposable income to actually pay for the hospitalization or other healthcare services. And that's me today. Thank you for your attention, and I look forward to your feedback.
Thank you very much, Wei-Lin. I think we only have time for one question. So, and the remaining one might have to catch him at lunch. So we'll start here.
Hi, Pauline Holland. I work for Te Whatu Ora. An application for a residential care subsidy is not usually submitted until the person determines whether their funding threshold, which is set down by MSD, is below that or coming in line with that. So they generally don't submit an application unless they believe from the information that was already provided that they will be eligible or not eligible. But I have seen cases where they've looked at the information and they will choose not to submit an application, or sometimes family don't want them to submit an application.
It doesn't. They could apply for a loan, but it's not well utilized. The application for a residential support subsidy loan, it's not well utilized. I don't know why, but certainly on the application, you have to, as a NASC, you have to put in where the person is going to be going and what their admission date is, and that's part of the application process. So it would be very unusual to make your subsidy application before you go in to residential.
I thought if they were at hospital level of care, high level disability, they got a partial subsidy automatically?
No, they get what they call top up. So there's a maximum contribution. So the maximum contribution that anybody in New Zealand, regardless of what their asset base is a maximum contribution that they make, and that sits at the residential care, rest home level care.
Yeah.
So if you're in anything higher than that, so dementia level care, then the DHB pay that top up.
So that top up is what they get automatically.
Yes.
But they still have to pay more if their assets are above the asset strip.
They have to pay up to the maximum contribution. Yeah.
And then of course there's the premium cost on top, which is completely optional.
Yeah.
But
well, is it? Because there's not many that don't have it.
So
no, there's several. There's,
Yeah.
I mean, you probably, somebody will know how many standard beds there are in New Zealand.
Yeah.
But yeah, yeah.
But we're finding, from a NASC perspective, we're finding it increasingly difficult to get people into standard beds. We come across a whole raft of reasons why the facility can't take somebody if they're the premium clause premium room clause isn't really serving the purpose.
I just want, I know.
You
Um,
have 10 seconds.
Wanted to ask about, so it doesn't take into account whether there is a family member who wants to or wishes to take care of them at home in their home. So, you know, Māori are very much less likely to opt to go into aged residential care. And I just wonder whether that's messing up some of that analysis.
Yeah, we were talking about that too. If somebody is that comment that people who get the subsidy tend to go into aged residential care healthier, that may be because they don't have the family support at home to support them when they become when their health status deteriorates. If there's somebody at home to look after them. So if you've got a subsidy, yeah.
Thank you, Wei-Lin. Definitely stirred a lot of questions.